Everyone. I'm Dr. Farnaz Haji. I'm a breast surgical oncology with UCLA. I'm primarily based out of our Ventura office and Santa Barbara, but I do have some coverage for our main campus in Westwood as well. Welcome. I'm very excited and honored to be here during October, which is Breast Cancer Awareness Month, to just share some of my information and expertise with you. So just as an overview of what we're going to talk about today is I'm going to give you a little bit of information about just cancer and cancer epidemiology in general, hallmarks of cancer, some of the new therapies that we have, and breast cancer diagnosis and treatments. As a breast surgeon, what I want you to know is that I want to discuss patient-centered approach to breast cancer surgery, and there's no one recipe for everyone, and what really goes into choosing the type of surgery that's best for our specific patient, and what does a personalized care plan mean for you. I do have a background in art. So besides the medical aspect of breast is always very fascinating to me from an art and historical perspective as well. Anytime I travel, I'm taking pictures of anything that has a feminine or breast component to it. Breasts throughout history have been featured in really ancient and modern sculpture, art, and photography. And the female breast has always been a symbol of beauty and fertility and femininity. They've taken different symbols throughout history. And however, in disease also, it's always challenged our doctors from ancient times. If we look at these three pictures, throughout the periods, we've really made a great progress in the medical management of breast disease. The historical milestones that brought us to surgical management of breast cancer to today's status is really remarkable. If you look at the picture on the left, it's a mastectomy in 17th century, and basically all they did was they just heated up some farm equipment and went at it. And the middle picture is showing a radical mastectomy designed and discovered by Dr. William Halsted at Johns Hopkins in 1894. What he believed and his theory was that in order to treat breast cancer, we need to remove everything on the chest wall. That included the breast tissue, the skin, the underlying muscle, the ribs, and all of the axillary lymph nodes. As you can imagine, this is quite morbid, and patients had a lot of issues long-term with that. And it's interesting, even though this is something that was designed in 1894, I still to this day get some of my older patients that they come to my office and they remember that their mother or grandmother had this type of surgery. So when we're talking about surgery for them, they're very frightened because this is the vision that they have of mastectomy, which was the very old school radical mastectomy, which we no longer do. And then the picture on the right is showing a modern mastectomy. It's a skin-sparing mastectomy, and the patient has chosen to have tattooing over her incisions. As you can see in these pictures, breast cancer and breast surgery has truly undergone a revolutionary change, leading us from that conventional radical mastectomy in the picture on the top that you can see to the era of just our traditional mastectomy, which is removing both breasts, but leaving a good amount of skin behind. And then the middle picture is showing skin-sparing mastectomy with reconstruction. And the last picture is nipple-sparing mastectomy, which basically the whole envelope of breast is left intact and just the breast tissue under that is removed. And patient has had reconstruction after that. So, as a cancer surgeon, I want to talk about this. Cancers, we all have somebody, a family friend, a neighbor that has been inflicted with some kind of a cancer. The number of death per 100,000 in the United States is shown here in these graphs and compared between 2019 and 2020. And as you can see, cancer death, and this is just general, all kinds of cancer death is the leading cause of death after any kind of heart disease. And this is a study that came out in 2023 in Journal of American Medical Association that showed that most cancers in the United States are found in people over age of 65. But this study specifically showed that cancer among young Americans, particularly women, is on the rise. in these graphs, we're seeing that in this study that they looked at 560,000 patients, even though cancers among older adults have declined, cancers among younger patients and younger than 50 have increased slightly. But the largest increase that's noted is actually in patients between age 30 to 39 here. And even more striking in this study was that early onset cancers in women has actually increased by 4.4%, even more compared to men, that has declined slightly. So as we can see, these numbers are something that we're actually noticing in our clinics also. It's not a month that goes by and I don't get a young patient. And it's very surprising to me and our medical oncologists that these younger and younger patients are presenting to our clinic with sometimes advanced breast cancer. So in the spirit of Breast Cancer Awareness Month, I want to just, talk a little bit about more statistics again in general. Approximately 1 in 8 women will develop breast cancer in their lifetime. The important thing is that also men are affected by breast cancer. The problem is that even though the percentage is very low, it's only about 1% of breast cancers, usually men present at a higher stage. Why? Because, men are men. Sometimes we need to really work hard to get them in our clinic. But at the same time, a lot of times they're misinformed. They've had a lump in their breast for a really long time and they just assume, oh, it's nothing. This is probably just a piece of fat that's in my breast, or, I got hit in my chest, so it's nothing. So generally, by the time they present to our office with some kind of a concern, their stage is higher. And early detection of breast cancer is extremely important because it allows us to offer patients higher and extended life expectancy, improve their quality of life while they're dealing with their cancer, and minimize the amount of surgery they need. So they don't need to have as big of a surgery, and also less medication and hopefully no chemotherapy for them. If you take a look back, the widespread use of screening mammograms over the past 40 years has really decreased cancer mortality in women because we're detecting disease at an earlier stage. And unfortunately, breast cancer screening during COVID dropped. And, if you guys remember, we had a lot of patients that would come in and they said, hey, for the past 2-3 years, I haven't had any mammogram. And this was even more notable in certain populations, such as our Latinx population, Native American, and African American and Hispanic patients. Unfortunately, what that translated into was that by the time the patients would arrive to us, the stage that they were presenting with would be a higher stage and needing more advanced surgery and more aggressive treatments. So, sorry, let me, this is not clicking. Okay, give me 1 second. I'm gonna switch this and see. 1 second. Pull this one back up. Okay, I think this is opening better. There you go. Okay. Right, let's try this again. Great, great, great. We are back. Maddie, are you still able to see my screen okay?
Yes.
Wonderful. Let me just flip this here. And all righty. Okay, we're back. Excellent. So we were talking about the last slide, we were talking about how the number of screening mammograms decreased during COVID and affected our patient population. This is another study. My colleagues at Mass General Hospital did a study that looked at nearly 230,000 patients with breast cancer, and 34,000 of them were African American. They compared the mortality rates of Black women and white women with the same type of molecular base and subtype. And they found that Black women were actually 17% more likely to die from triple negative breast cancer, which is one of our higher mortality type of cancer. And the question was that, so why is it that this population have a higher mortality rate? If this is a high mortality rate type of cancer, why is this specific population are actually their mortality rate is higher? So some of the answers that they were able to come up with was that a lot of African American patients, there's a lack of representation in research and clinical trials because of our historical misuse of information and misuse of African American patients in clinical trials. A lot of our African American patients are reluctant to participate in clinical trials. And there's also social determinants of health. And this is not just access to having a good doctor, but it's also what do you do, if you have a doctor's appointment with childcare? What do you do for transportation to and from your appointments? And what do you do if you need to take time off from your work? And also other environmental factors such as access to healthy food and living in an area with low levels of pollution. And also another factor that they noted was that many of these patients actually had delayed detection due to lack of access to appropriate healthcare. So I want to talk about how does cancer work. This is something I think we need to understand. It's a little bit of science talk. I promise we'll make it short, but you really need to understand how does cancer work? And this is not just breast cancer. How does cancer, trick our system? Because cancer is not a disease that's coming from somewhere else. It is the cells of our own body. The cancer process is really a result of a very complex interaction involving diet, nutrition, physical activity, and other environmental factors, and the patient's own host factors and their genetics. And it usually takes a while for normal cells to transform into invasive cancer. Cancer, I always say, it's a smart disease. So how is it able to do what it actually does is that most cancers have learned or acquired a set of functional capabilities during their development. Our body is pretty smart. Our cell cycles are pretty smart. We usually have stop point. If there's an error in cell replication, our body has mechanisms to be able to destroy those cells that are abnormal. But cancer, being made out of our own cells, has kind of learned techniques to bypass some of these traffic stops that they were supposed to have. They are able to teach themselves how to send their own growth signal. So they're basically telling their own abnormal cells, keep growing, keep replicating. And they also become insensitive to anti-growth signals. So, at some point, why is it that, you don't have lumps all over your body? Is that because once cells reach a certain point, there are anti-growth signals in place that tell the cell cycles that this is the time that you need to stop. And they also bypass programmed cell death. This is a normal mechanism that our body has. It's called apoptosis, which is when you have abnormal cells, your body's able to get rid of those. And the cancer cells have learned to bypass this stop point as well. Also, cancer cells, one of their main features is that they grow a lot and they grow fast. That's why a lot of times our patients that have advanced disease, they become cachectic, they lose a lot of weight because the cancer cells are reproducing so quickly and utilizing body's nutrients and oxygen to grow. And they do that by way of basically generating new blood vessels for themselves. So when I'm doing breast surgery, a lot of times when I'm, dissecting around the lump or around the tumor, I notice that it's a lot bloodier. This cancer cell has taught itself how to recruit more blood vessels so they can basically steal more food and oxygen so they can feed this giant tumor that they're growing for themselves. This slide is quite busy. You don't need to read all of it, but basically, I wanted to kind of show the studies have been done that show the potential impact of diet, nutrition, and physical activity in increasing the rate of cancer through helping the mechanisms that I talked in the last slide. It's your diet and obesity can affect the rate of increase and unsurveilled growth of cancer cells. So this is something that has been studied extensively, the connection between nutrition and obesity. And studies have shown that only about half of Americans are really aware that obesity can be a significant contributing factor to cancer. Obesity in our terminology is determined as BMI of greater than or equal to 30. And obesity can increase a person's risk for 12 different types of cancers, including postmenopausal breast cancer, colorectal cancer, even pancreatic cancer, and advanced prostate cancer. What I talk about with my patient is that weight loss doesn't need to be something huge. You don't need to go on some, exotic diet to lose a lot of weight. Even very modest amount of weight loss of even 5 to 10% of someone's total body weight can really help reduce many of these risks associated with obesity and cancer. And patients always ask, this is something that they want to take charge and be in control of, like, what can we do? What should I eat? What should I not eat? Usually, the one diet that is strongly recommended by me to my patient is Mediterranean diet, which is something very high on vegetables, fruit, legumes, and mostly fish, and not a lot of red meat, and a diet that's very low on sugar and processed food. That being said, I always tell my patients, I'm a very moderate doctor and surgeon. If you're somebody that you want to prevent cancer, this is the diet that you want to adopt. But if you have cancer and, this is today, you got diagnosed with cancer, I'm realistic. I get it. You don't need to cut out everything from your life all at once. It's all about moderation. It's all about decreasing the amount of things that you're eating. But if you're sad and you need to go home and have a bite of a brownie, that is okay. That is not going to give you cancer. It's all about your lifespan and what you're doing on a more long-term basis. Another thing that we talk about is the numerous studies that have shown that cancer risk rises with heavier drinking, especially when I'm talking about that is binge drinking. We're in Santa Barbara. There are a lot of wonderful vineyards around us, but we're talking about mostly is binge drinking and excessive drinking, and that's more than 3 drinks per day. And why does that matter is that excessive alcohol consumption can cause DNA damage. And this is through a process of some enzymatic activity that excess alcohol can turn into acetaldehyde, and especially in our Asian American population, they lack some enzymes to be able to convert the alcohol, and this increased acetaldehyde in the body can cause DNA damage. And also having increased alcohol in the body can increase level of estrogen in your body. And estrogen plays a major role in postmenopausal breast cancer that is associated with higher levels of estrogen in your blood. So we said all of this. Tell me what I need to know. Tell me what I can do to help myself, help my sister, help my mother and family members in detecting breast cancer. So as far as early detection, there are a couple of things that I usually recommend for patients. Doing self-breast exam, doing clinical breast exam by a medical doctor, that can be by a breast surgeon like me. It can be by your gynecologist or your primary care, and also doing official mammogram and ultrasounds. So what are we looking for when we're doing self-breast exam? I usually say for my postmenopausal patients, just pick a date, let's say first of the month. That's when I usually do my breast exam. For premenopausal patients, I usually recommend doing it around 7 to 10 days after their menstrual cycle has ended. And I usually say after shower, you just stand in front of the mirror, you just look at your breasts. What do my breasts look like? Is there any asymmetry? What do my nipples look like? And then I also have the patients raise both arms up and look at the breast again. Sometimes some of the deformities actually pronounce themselves more when your arms are raised. And then you want to touch all 4 quadrants of your breast. So upper inner, upper outer, lower inner, and lower outer. And you also want to examine under your armpit just to make sure there is no new lump. This is just for you to become familiar with your anatomy. There are many women that have very complicated anatomy. Maybe they've had previous surgeries. Maybe they have really lumpy breasts. We understand that, this is not the only thing that we're relying on. This is the whole goal of this, is for you to just be more familiar with your own anatomy. When patients come to me, I also have them fill out a questionnaire for me. These are the sort of things that, are you at an increased risk of developing breast cancer? Is there family history of breast, ovarian, advanced prostate, or pancreatic cancer in your family? And is your family of Ashkenazi Jewish population, which have certain gene mutations that increases their risk of breast cancer? And also if they've had any previous biopsies or any previous abnormal imaging. We talked briefly about genetics. Usually a lot of patients are familiar with BRCA1 and BRCA2, which are the 2 most known gene mutations in breast cancer, but they're actually a huge panel, at least 8 or 9 genes that we can run for breast and ovarian cancer specifically, and we can expand that to include 93 genes that looks at other cancers such as colorectal, pancreatic. It just depends on how many you're willing to get tested for. So one of the biggest things that I always advocate for is when do we start screening? So historically, over up until actually April of this year, there were a couple of different guidelines. American College of Radiology, American Society of Breast Surgeons, they were all saying start at age 40, start at age 40. Why? Because in our clinics, we were seeing all these younger patients that were presenting with breast cancer. And American Cancer Society and USPST, they were a little bit more lenient. They're like, oh, start at 45, start at 50. I think some of that, to be honest, had to do with insurance coverage. But I think if we can really catch one patient earlier, that is worth it. So this year, actually in April, USPST also changed their recommendations, and they recommend everyone to start at age 40 and continue with annual imaging up until age 74 or until the patient's life expectancy is less than 10 years. I work in our region, in Ventura County and Santa Barbara County. I mean, I have patients that come in from their pickleball at age 85. And, for that patient, I can see that they're going to be living more than 10 years. So I'm not going to stop just because, they're past 74. I'm going to keep monitoring them as long as I feel like that they're healthy and they're going to live more than 10 years. Another thing to consider is that for patients that are at higher risk, meaning that if they have family with breast cancer or they're just in general consider higher risk, I usually try to supplement their mammogram with an ultrasound and MRI also. Something that's a hot topic that, comes up, and it's actually become a law in California and many states in the United States, is that for patients that have dense breast tissue, they need to get mammogram plus ultrasound. So what is dense breast tissue? If you look at this image, on the left side, this is a breast that's almost entirely fatty. So you can kind of see through it fairly well with the mammogram alone. As you go and move to the right, you see the amount of white is increasing. That means this patient has more ducts, more glands in their breast. So their breast is more dense, and mammogram alone cannot detect abnormalities. If you look here in a patient that has really fatty breasts, this is the cancer in the middle in the red circle. You can kind of detect it fairly, and it's obvious. But then when you go to someone that has more dense breast tissue, they have a lot of white tissue, and then you put a little white thing of cancer in the middle of that. It's almost looking for a cotton ball in the middle of a snowstorm. It's very difficult. So for those patients that have higher density, it's usually at the bottom of the mammogram. It says, you have, heterogeneous breast tissue. Those patients, they need to get at least an ultrasound with their mammogram annually. So don't forget supplemental ultrasound with your mammogram if you have dense breast tissue. So a lot of patients come in and, once they're diagnosed with breast cancer, they ask about breast cancer staging. And breast cancer staging it's not just the size of the tumor. It's not the size of the cancer. Staging is based on the size as one of its components. Also, if there is any axillary lymph node involvement, meaning that has this cancer spread to somewhere outside of the breast tissue in the armpit. Some of the things that we're including in our modern staging is the biology. You can have a small cancer, but it can be an aggressive cancer. So we look at if the cancer, it has an estrogen receptor, progesterone receptor, or HER2 receptor. So again, it's not, you can have a very lazy cancer that's large, which just means, it's been sitting there for a long time and maybe you missed some mammograms, but not every large cancer is a high stage cancer. I know we have a mixed population of audience of who's present today, and this is also being recorded. So I wanted to just briefly talk about breast cancer in young patients, because it's something that we're noticing more and more, and I'm hoping to be able to pass on this information to everyone who's present here so you guys can share this with your friends, family, daughters. This is a patient of mine, actually. She is a 26-year-old. She just moved to a new city for her college and her new job. And she herself felt a mass in her breast, which made me very curious because, which 26-year-old is doing breast exam on themselves? And it turned out that she actually was watching a TikTok video on breast cancer monitoring. And she saw the video and did the breast exam on herself and found this mass. So I guess there's some good in TikTok. But this patient actually ended up having a kind of an advanced disease, a larger mass, lymph node involvement, and a more of an aggressive type of breast cancer with triple negative. So nearly 13,000 women are diagnosed with breast cancer that are under age 40, and 26,000 women are diagnosed annually that are under age 45. This group of patients in general are called adolescent and young adult, or AYA, which is patients with cancer aged between 15 to 39. And in this group, breast cancer as a percentage of all cancers in AYA patients is roughly 30%. So high number of these patients exhibit breast cancer. Here, we know that breast cancer in young women is still a rare entity, and I think that's why a lot of times we don't talk about it very much. But once younger women have breast cancer, their mortality, unfortunately, is also higher. On this left graph, what it's showing us is that the incidence of breast cancer goes up with age. So younger patients are less likely to have breast cancer. But the graph on the right is showing us is that the survival dips in women diagnosed in their 20 and 30 here in this area. This is for a variety of reasons. Many times it's due to delay in diagnosis, which is common. And sometimes it's related to the nature of the disease. It's the tumor biology. It tends to be more aggressive type of cancer. These patients tend to have more of triple negative breast cancer, which is a more aggressive type of cancer. And we mentioned this, and I wanted to bring this up because timing is very critical. It's critical in all cancers, but in this specific population, it's very important. Any delayed in diagnosis, anything greater than 6 weeks, can actually substantially affect mortality in these patients. So it's very important that when patients present to us, even if they're young, in our community setting to, gynecologists or primary care doctors, and they have a concern, if they're young, for us not to dismiss it easily and say, oh, you're young, this is probably a benign fibroadenoma. You don't have to worry about it. I just want to reiterate this, that, breast cancer happens in these young patients, and it delays in their diagnosis can significantly impact their survival. And this is even quite amplified by race, and Black women's survival probability, which is shown on the graph on the right, is much more impacted by any kind of delay in their diagnosis. So for my patient that I talked about, and any young patient, premenopausal patients that present with breast cancer, there are many issues that kind of complicate their treatment pathway. These patients are generally not included in our clinical trials because they're younger. And because of that, the data and the medication and treatments that we have doesn't have good implications for them. Sometimes these patients are diagnosed even during their pregnancy. The treatments that we offer them, the medications that we give them, sometimes it causes early menopause in them. It affects their fertility. So it's very important that, when they present to us, when this patient presented to me in that first visit, she had 6 different referrals to medical oncology, radiation oncology, to a fertility specialist, because if they're interested in preserving their fertility, they need to be at an institution that can offer all those services to the patient expeditiously. And there's also, the financial difficulties associated with that for any cancer patient, especially, for this young patient that had just started college, that, had just moved into a new town. We had to write letters to her university, to her landlord, to say, hey, she needs to break her lease because she needs to get treatment, and she needs to move closer to home. And obviously for younger patients, the body image issue is also a huge thing. Many of my patients come in, we talked about the wig event that's coming up. That's a huge thing. I have patients that come in and they ask 1 or 2 questions about their treatment, their chemotherapy and surgery. And at the end of it, all they're asking about is, am I going to lose my hair? Because that's just a very obvious way, and it's a very public way that everyone will know that this patient is dealing with cancer. And it's not just a aesthetic thing. I think a lot of it is medical and psychological for these patients also. So another topic which very frequently comes up in our young cancer patient visit is contralateral mastectomy, or having bilateral mastectomy for a disease that is only in one breast. And it became a lot more noticeable in our clinics from 2013, when Angelina Jolie had a prophylactic bilateral mastectomy, and it was mentioned in the Time magazine. So we call it the Angelina effect, which was in her case very appropriate because her mom passed away from ovarian cancer, and she did have the gene mutation, and she decided to have bilateral mastectomy for that. So the rate of contralateral prophylactic mastectomy, which is having a mastectomy on the opposite side, so the side that the patient doesn't have cancer, has really gone up in the United States over the past few years, but it's also gone up substantially, almost 4 times more in our younger population. And when we look at the survival advantage of this, studies have really not shown that doing a double mastectomy in these patients, if they do not have gene mutations, really doesn't have any survival advantage. So, I share this data with my patients during their visit, but ultimately what it comes down to is the psychological decision for them, because they don't want to go through this one more time. And in their mind, if they have a bilateral mastectomy, this is the best way to prevent them from having cancer again in their life, which oncologically, that is not correct, but psychologically, that's something that helps them. And to end this segment of talking about women with young women with breast cancer, we've truly lost some magnificent young women in our community. Dr. Maryam Mirzakhani was the first female mathematician that won a Nobel Prize in math. She was a professor at Stanford University, and she passed away from breast cancer. So this is really an area that requires more research for us to be able to help some of these exceptional women that we have in our communities. So to change it up a little bit, let's talk about, so what happens in preoperative evaluation when somebody comes in and they have abnormal imaging. The patient comes in, we need tissue. We need to know, okay, if you had abnormal imaging, what's happening in that breast? So we send the patient for a biopsy. This can be done under ultrasound or under mammogram, depending on what kind of a lesion or abnormality they found. Ultrasound biopsy is usually the easiest. They just put a probe, they run it on your breast, they go with the needle and take out a tissue. If it's something that's not seen on ultrasound or more difficult or better seen on mammogram, we send the patient for mammographic biopsy, which we call it a stereotactic. Sometimes the patient needs to lay down on the bed, and sometimes they're seated, and basically they find that abnormal area under mammogram, they go in with the bigger needle and they do the biopsy. At the time of biopsy, the radiologist will then put one of these tiny little clips in there. As you can see, they're super, super tiny. You can really only see them on mammogram. So at the time of surgery, I'm not able to see this. This is only visible on mammogram. So they do the biopsy, they take that specimen, they put a little clip there to show that, hey, we were here, we biopsied this area, and they send that tissue to pathology. And then the pathologist will look at it under microscope, and they give us 2 types of diagnosis. It's either malignant or cancer or benign entity. And then if it's a benign entity, we'll have a discussion with the patient whether or not they would still like that removed. And if it's cancer, we'll discuss their surgical options with them. So what are the types of surgery that we can offer our patients? One of the most common types of surgery that I offer my patients these days is lumpectomy. Lumpectomy is going in and just finding that abnormal area that was seen on mammogram or ultrasound that was biopsied, and just removing that specific lump and leaving the rest of breast intact. The goal of lumpectomy is removing the cancerous area and making sure we have negative margin, meaning that there's nothing on the outside of our lump that still has disease. How do we do that? Again, this is that tiny little clip that the radiologist plays for us. We either put a wire, it's basically a dart saying, hey, Dr. Hadji, go here. This is where you need to excise. And more modern techniques that we have, instead of putting a wire, we do one of the things that we have here in Santa Barbara and Ventura is we do these Savvy clips, which is a radio frequency clip. We put it in the breast ahead of time. It can be you can do it 6 months before, a week before, or the day of surgery. And then at the time of surgery, I have this probe that I run it on the breast. And when it gets close to that lesion, it beeps for me. So then I know, okay, I'm right over the mass or right over that lesion. And then I know I can go specifically remove that. Patients usually like this because they can do this ahead of time. And at the time of surgery, they're just ready to go and they don't need to come in earlier and get a wire placed. But we individualize it based on what works better, based on the facility, patient scheduling, and patient's comfort. So that was for lumpectomy and removing part of the breast. The other topic is mastectomy, which is our bigger surgery. The types of mastectomy that we have is we have simple mastectomy, we have skin sparing, nipple sparing, and modified radical mastectomy. This is a skin sparing mastectomy, and since nipple and areola were removed, and this was the site of the patient's incision, patient chose to have a 3-dimensional tattoo at the site of their surgical scar. In nipple-sparing mastectomy, this is very similar to skin-sparing mastectomy, except we just leave everything, the nipple, the areola, the skin. I usually use the example of think of your breast tissue as a pillow and your skin and areola as a pillow cover. When I do the mastectomy, I lift this, I remove all the breast tissue, and everything on the outside stays intact. And our plastic surgeons will go in and fill up that empty space with some kind of an either implant or other types of reconstruction that I'll talk about. Something else that we always do at the time of our cancer diagnosis, we always want to know, has the cancer spread? Has it spread anywhere else outside of the breast? And for that, we do lymph node assessment by doing lymph node biopsy, which means we're only removing the first few lymph nodes. Usually ends up being around 2 to 3 lymph nodes to prove that if the disease has spread or has not spread to the axillary lymph nodes. If you remember from that first picture that I showed in my PowerPoint, we don't do axillary lymph node dissection, which is removing all of these lymph nodes. You have around 30 or 40 lymph nodes in your axilla. So a lot of times people talk about, oh, having arm swelling after axillary surgery. Generally, that's talking about axillary dissection, which is removing all of these lymph nodes. When we do more selected biopsy, which is removing only 2 to 3 lymph nodes, the possibility of lymphedema or arm swelling substantially goes down. So I just want to briefly also talk about breast reconstruction. This is Breast Cancer Awareness Month. Really, one reason that I'm able to sit here today with you and provide this talk is really thanks to many previous surgeons and women's health advocates who championed for better healthcare and insurance coverage for women with breast cancer. The Women's Health and Cancer Rights Act of 1998 said that if an insurance company covered mastectomy, they were also required to cover reconstructive surgery also. And that also includes doing reconstruction on the other side. And this really opened up the door for patients being able to have access to reconstruction. I mentioned this, but unfortunately, even in our wonderful region, with many resources, we do have issues with reconstruction. We have wonderful breast reconstructive plastic surgeons, but because of insurance limitations, even in our own Santa Barbara County, many patients are not able to get immediate reconstruction because the insurance payments are so low to our plastic surgeons. And many plastic surgeons, and you guys know, I don't need to tell this to anyone, it's expensive to live in this area. So, and for their staff to be able to survive, the insurance payments for breast cancer reconstruction has been so low that many plastic surgeons have had to pull out of insurances. And for many of my patients, even though they have insurance, they're unable to get reconstruction. And we have to send them to other facilities such as UCLA main campus to get this. And this is something that I urge you as women that are joining us in this conversation today is to petition whoever you have. If you have somebody, from your insurance company, if you know somebody, if you have somebody that's has any pull in this, is we need to advocate for ourselves. And this is something that is felt nationally in the United States, but it's definitely something that even in our area, I'm feeling it more and more every day. And it's one of the saddest part of my conversations with my cancer patient that at the end of it, they may not be able to get immediate reconstruction or reconstruction at all if they're not able to pay cash for it. So as far as the types of reconstruction that we offer our patients, when I do my lumpectomies, when I do those smaller surgeries, I do oncoplastic reconstruction for them, which means I remove a hole, I try to fill up that hole so there's not a dent in patient's breast. So I rearrange the tissue and kind of cover that space to make sure that they have a smooth contour by the time I'm done. I also try to do hidden scar. I usually almost never, make a cut on the skin. I always either try to make an incision around the areola, sometimes in the axilla, sometimes in the line that you have under the breast, basically try to hide this scar as much as possible. I also collaborate with our plastic surgeons when possible for implant reconstruction. So, I do the mastectomy and they will go ahead and place an implant, sometimes over the muscle, sometimes under the muscle. And another type of reconstruction that we have is flap reconstruction. It's a much bigger surgery. It's basically almost doing a tummy tuck. So we remove the fat from patient's abdomen and transfer that with the vessels attached to their breast area and recreate a breast for them. It's a wonderful surgery. It's a very lengthy surgery, but patients are generally very happy with the final results because it's their own tissue and it just kind of ages with the patient the same way as the rest of their body. This is being that it's a complicated surgery, I usually recommend this being done in bigger institutions that are more familiar with this, because there's a higher rate of failure if you do it somewhere that, they don't do this very frequently. And another thing that more and more I offer my patients, and patients are very intelligent, educated, and they come in and ask for it, is flat aesthetic closure. It's, basically once the mastectomy is done, just closing the patient. But when I talk about flat, it's really making the patient flat. And this is what we're talking about. This is not a flat closure. There's no contouring. When we do aesthetic flat closure, we make sure that the patient is as flat as their anatomy allows, so they can really just be free. And this is something that, it's really a patient's choice. I have very many young patients that come in to request this, and I have older patients that they request this because, they don't want to have an implant in their body. So what happens when I'm done with my surgery? Usually we make a referral to our medical oncology and radiation oncology colleagues. My medical oncology colleagues will determine what needs to happen after surgery. We call that adjuvant treatment. So if the patient needs chemotherapy, they can do testing on their specimen, their surgical pathology, and do a test called oncotype testing. Oncotype testing basically determines if there's an advantage for receiving chemotherapy for them or not. My medical oncology colleagues also sometimes prescribe endocrine therapy in the form of tamoxifen and anastrozole, and this is only prescribed for cancers that have estrogen receptors, so we call them estrogen receptor positive cancers. If needed, after lumpectomy and sometimes after mastectomy, we also have the patients have a conversation with a radiation oncologist, and they will receive radiation. Generally, the standard treatment is something 4 to 6 weeks. Patients go for 5 days a week. It's very quick. It's cumbersome because you have to go every day, but it's usually pretty fast. You go in, it's almost, doing an X-ray and you're done. Most of my patients are functional. They go to work during that time, and it's not very limiting to their lifestyle. So I wanted to end the talk with talking a little bit more about modern treatments that we have available. We have patients here that have already undergone their cancer treatments. I really want to plant and end the conversation with a positive note of the advances that we've made in breast cancer treatment. At UCLA ourselves, we're really pioneering many of the new treatments for treating breast cancer. Historically, one type of breast cancer, which was HER2 positive, was one of the deadliest breast cancer. But thanks to our own Dr. Dennis Slayman, he discovered this medication called Herceptin, which is used for this specific type of cancer. It's anti-HER2 medication. And because of this medication specifically, the survival of these patients has become equivalent to some of our less aggressive types of cancers. So we're really thankful for these new medications that are helping our patients have a better chance at fighting their disease. And that doesn't stop there. We're constantly, coming up with new treatments. We're very involved in immunotherapy, which is using medications that actually activate your own immune system to attack the cancer. And also, remember when we talked about the cancers create this basically a cloth over themselves. So, it's a camouflage that our immune system does not see that. Some of the immunotherapy actually removes this camouflage that these cancer cells have provided. So they're not really going and killing the cancer, but they're waking up our own immune system to go and attack these cancer cells. This is very revolutionary, but in reality, it's not a new topic. This is something immunotherapy has been noted and used historically in ancient Egypt and even in Europe. And they noted that some patients that had cancer, if that cancer got infected around it, the cancer actually decreased in size. Why? Because of the infection. The infection kind of awakened the patient's immune system. And when the immune system went to help with the infection, it also helped with minimizing that cancer also. And we're sort of utilizing the same theory in applying immunotherapy for our cancer models. Another treatment modality that is becoming more used in our cancer treatment is CAR T cell therapy. This is a type of treatment where a patient's T cells are involved in your immune system, are changed in the lab so they will attack the cancer cells. basically they take the T cells from a patient's blood, then a gene for a specific receptor that binds to a certain type of protein on the patient's cancer cell is then loaded on that T cell in the lab, and then we give that loaded T cell back to the patient. And this loaded T cell would then go and attack the cancer cells. Kind of the same model. There's another group of drugs called antibody drug conjugates, or ADC. This is, again, how does antibody work? Is that antibody will go and attach to the surface of a cell. So they've designed these antibodies and attach the medication or chemotherapy specifically to these antibodies that will go and then attach to the surface of the cancer cells. And because they attach, they can internalize themselves and go inside the cancer cells. Once they're inside, that's when they release their medication and their chemotherapy. So they're only targeting the specific cancer cells that they have these basically lock and key model that sees this molecule, internalizes it, and then once it's inside, it's kind of like the Trojan horse. You go inside and then it releases the medication and only kills the cancer cells and does not have more of a systemic side effect all across the body that we see with more traditional chemotherapy. So I mentioned all of this just to kind of end the conversation with saying that finding breast cancer really at an early stage gives women the best chance of survival. We really need to try to encourage everyone to be breast aware and ensure that our screening programs are effective for all of our patients from all background, and also find new technologies and new innovations and new medications to detect breast cancer and treat breast cancer at an earlier stage. And where do we go from here? I always encourage patients, know your history, know your own anatomy. Holidays are coming up. I'm very fun at parties. I'm always asking my family about, well, what disease do we have? How did aunt so-and-so pass away? It's important for us to be familiar with our own family history, also be familiar with our own anatomy, with our own body, so we can be the first person noticing any change. Because catching any breast cancer, as I've mentioned this multiple times during this talk, catching breast cancer at an early stage really increases the odds for successful and less invasive treatment for our patients. And we truly do have effective treatments. I kind of joke with my patient, if anyone, cancer is never a good thing, but if there's ever a time that somebody wants to get cancer, this is the time, because we really have very effective treatments for treating breast cancer. And if there's ever any question, any doubt, please feel free to reach out to me and our team at UCLA at multiple locations that we have. And with that, I thank you for your time, and please feel free to ask any question. This is my wonderful team at one of the hospitals in Goleta and Santa Barbara, and this is me at our UCLA Surgery Center. Thank you for your time, and I'm open for questions.